of directors with me at the Alzheimer's Association. Dr. Kate, as I call her, she told me, just call me Kate, please. But it's out of respect that I do call her Dr. Kate Glywasky. Did I get that right? All right, fabulous. Dr. Kate came to us this year to be on our board, and one of the things that I found about her enticing is her sense of humor and her flexibility. And Dr. Glywasky is a board-certified clinical neuropsychologist and a licensed clinical psychologist. She's been practicing for more than a decade through the United States, and Dr. Glywasky completed her undergraduate and doctorate degrees in Florida, attended residency training in Georgia, and completed her 2-year postdoctoral neuropsychology fellowship. That's a mouthful. At Brooke Army Medical Center. So she's also a new mama, and I'm so thrilled that she showed up and ready to work today because she does have a newborn. And I'd like you to help me welcome Dr. Kate Glywasky.
What I do want to talk about today is normal aging versus dementia. So there's been some questions when we were on the break before about some people saying, you know, I've been diagnosed potentially with MCI, mild cognitive impairment, or maybe early Alzheimer's, or I've been noticing some changes as I've gotten older. So the hope, my hope for you after this talk is that you'll have some additional information to form your own understanding of potentially what's going on and if there are any changes in your brain or the brain of somebody that you love. So with that being said, if we can go to the first slide. Or do I have, I'm the master of my own domain up there. Okay. So again, talking about dementia versus aging, Dr. Boyle spoke a lot about dementia being a syndrome, which is absolutely correct. It's a group of symptoms potentially, but itself can be very misleading if you throw around the term dementia because it can mean various different things. I'm going to also talk about the course and etiology of Alzheimer's, notable characteristics and cognitive patterns. And that will include different types of dementias. So obviously Alzheimer's is the one that we know the most, but there are other dementias that I'm going to cover as well, because I think that's important since we want to address the overall understanding of aging as we go through that process. Also the use of neuropsychological testing. So again, factoring in, if you think of dementia sort of as an umbrella or a syndrome, there's various different types. Some are reversible, something like depression, something like sometimes a brain injury of some sort, or a person gets a stroke and not necessarily gets an amnestic disorder, but recovers from that stroke. So again, dementia can be both reversible and non-reversible. And the idea behind it is that there's at least 2 areas of functioning that are impaired. So when I talk about 2 areas, I'm talking about the core functions of your brain. And if we can split it sort of in a way obtusely, we're looking at memory, of course. And there's different types of memory which we'll go over. I'm talking about language, which is verbal expression, verbal reception, fluency, syntax, all those sorts of things. And then also we're talking about motor skills and executive functioning, which is the part of us that allows us to be the master of our own domain, and in terms also looking at visual spatial skills. So what we know about Alzheimer's, again, you guys have been a part of the lectures earlier on Alzheimer's, and the idea that it is a neurodegenerative brain disease. What that means is that right now we have no cure, and that essentially whether or not you're in the earlier initial stages, we can assume that you will get worse. There is a gradual onset. So when I have a patient that comes to me and will say, you know, all of a sudden, I just, don't have any memory. I have memory problems. It's a gradual thing. Most of the time, individuals will, with Alzheimer's, their family members are more the ones who have the information as well, but they will start to say, you know what, it's sort of, I can't really pin when it happened. And that's kind of what with the resemblance typically starts. It impacts people age 50 and above, and of course we know it impacts people much earlier who are caregivers of these folks. And again, women. Women are affected not only because they're more likely to live longer, but also because they are caregivers. I didn't know until I gave an earlier presentation to the Alzheimer's Association that there are more people over the age of 85 in this country than there are under the age of 5. So that's something to think about, especially as medical advancements continue. So again, looking at the different types of, there's gene mutations, which was covered earlier, and the most common risk factor for Alzheimer's is aging. So a lot of people will say to me when they come and for an evaluation, they'll say, well, you know, my father had it at 90. Am I going to get it? I'm really scared. I'm in my 70s and he was 90. Now, if you understand or are aware of some of the statistics, 1 in 3 people over the age of 85 will get Alzheimer's. So sometimes I'll talk to them and other people who may disagree with me, but I'll talk about the importance of good genetics. And to me, somebody who could live till 83, 84, 85 tends to have pretty good genetics. So the longer, again, that we're living, the more we're struck with the idea that we're more at risk. And of course, currently there are no biomarkers. Diabetes, we have insulin levels. Obviously, breast cancer, we have biomarkers now. So again, the importance of participating in clinical trials, participating in research, advocacy, these are all things that are critical for the advancement of knowledge related to the cure. So anatomy of Alzheimer's. I love brains, okay? So there's going to be some brain pictures here. I'm also a very visual person, so maybe this was for my benefit, and I apologize, but I thought maybe you guys would enjoy the pictures. So if we look here, and I'm going to try to get this little zapper. Okay. So if we look here, down toward the bottom, you can see where it says to the right, the hippocampus. Okay? So the hippocampus is the area of your brain where we know is, what we know from theory is that that's where the beginning of Alzheimer's starts. The hippocampus is responsible for the formation of memories. Okay? So looking again, the hippocampus, which is Greek for hippo meaning horse, campus meaning sea monster. So if you look, it resembles a seahorse. And so the hippocampus severely shrinks. And what causes that then is that the areas around your brain start to fill up your ventricles and essentially causes more of a shrinkage in your brain, which you'll see here. Okay, so the average brain weighs, they say, about 13 to 1,400 grams. So that's about, I did the math before I came here, that's about 2 to 3 pounds. Okay? Somebody with Alzheimer's, because we're talking about tissue loss, their brain is going to weigh about 1,170 to 1,260 grams. Okay? So as you can see, there's a loss of volume. Initially, it starts in the hippocampal region. But the hippocampus, again, does not store the memories. It's suggested that the area next to it, the memory bodies, are the ones that store the memories. So Alzheimer's, again, we've talked a little bit about what happens. Okay, there's the amyloid cascade hypothesis. There's many different hypotheses. I can talk here now and make a liar out of myself in 10 years. Okay, because we're learning so much that what I say now versus 10 years, hopefully there'll be so much more that we'll know. But the amyloid cascade hypothesis is generally the most well accepted, but there are other theories behind Alzheimer's. But again, you have these clumps of protein. The protein that makes the amyloid basically becomes mutated, or essentially what's left over or fragmented it's insoluble to the brain, okay, essentially. So what occurs then is that you cannot, the areas around are not going to be able to function around it, so there's going to be neuronal loss. So these plaques develop, okay? The plaques develop out in between the cells, which causes then the neuronal loss. So this is another picture of this, but we'll keep on going. Now, I know the Alzheimer's Association talks about 6 stages, and I think for the purpose of kind of quantifying, there's other people that talk about different stages. You know, in the past, we've always talked about the first 1 to 4 year mark, 4 to 6 year mark, and 7 to 14, because we assume that people with Alzheimer's will tend to live around 7 to 8 to 14 years, but again, it's always changing, okay? But the first stages, the initial complaint or initial problem is going to be the formation of memory, short-term memory. So if somebody says to me and comes up to my office and says, you know, I don't remember my wife's birthday. Well, is she a new wife, right? Did you meet her yesterday? Okay? Because if you can remember everyday things, but you can't remember your wife's birthday, you know, that might be something else, okay? I'm also a psychologist, all right? But seriously, okay? So we want to talk about, because in the later stages of memory, in the later stages of Alzheimer's, people will forget those important things, okay? But in the earlier stages, it's going to be short-term memory. There's going to be some word-finding problems. What is that word? What is that word I'm trying to think of? And that happens actually to everybody, okay? But we're talking about more frequently than most. And again, if they're concerned about memory, rule out what they used to call pseudo-dementia, which oftentimes is depression. Okay? Depression is very common, especially as people get older. You lose your loved ones, you lose your support, you lose your confidence. So a lot of times, this concern can be oftentimes helped with talk with your doctor about whether or not it is depression, because that's fixable. And that's a great thing if that's something that you find out that that's what's partly accounting for this. Now, your MRI of your brain, this is looking at MRI. There's also DTI, and before they were talking about PET imaging. For the MRI of your brain, a lot of times, if they're not looking for it, they're going to miss it, okay? Especially in the earlier stages. So if you say, okay, well, I'm starting to get memory problems. I also have migraines, so I was able to talk to my doc, and he ordered MRI, and it's fine. So I guess I don't have a problem. That's not necessarily correct, okay? What I tell those people is to continue to follow up, write things down of what their concerns are, speak to people who love you, speak to people that like you, and say, you know, what do you think? You know, how are you with your memory? And if they're noticing changes, that might be something that then you can go back to your doctor and bring the caregiver and say, yes, you know, this is a concern. So normal aging, okay? This is the part to me that I think is most important because it's happening to all of us. And what we know generally is that our cognition peaks between 18 and 30 years old. What should remain intact as we get older? Our vocabulary, for the most part, okay? What other things? Visual spatial skills, for the most part. Arithmetic, simple attention, comprehension. So you're in a conversation, you get what's going on. Always check and make sure if the person can hear well or see well. But again, these are things that should remain intact till around age 75. And what we know about that is that there is maybe a potential decline after 75. Now, you also want to figure out, is this a new change or not? Okay? And this is really important because I myself am horrible at attention. Okay? I remember growing up and my mom took me to an audiologist because she was convinced that I couldn't hear. And the audiologist, and this was before everybody was getting, you know, diagnosed with different things, the audiologist says, no, she can hear fine, she just doesn't pay attention. And many would argue, many would argue that still hasn't really improved much. Okay? But we all have our ways of compensating. But many people were never good at math. Okay? And everybody gets along fine with that. You just find what works for you in your life. But don't expect that as you get older that it's going to get better. Okay? But you want to be able to say, well, I've never really been good at short-term memory. And maybe some people don't know. And if you're, you know, very well educated and you've relied on your memory, or you're educated and, you know, you've done something and had, you know, really good memory, and it starts to decline, then you would pay attention. The same thing with visual spatial skills. okay? So the optimal versus the typical cognitive aging. There are folks out there called superagers who actually do very, very well as they get older in their 80s, and essentially their memory just continues to improve as they get older. And we're studying those as well, because that's really important to know what is it that they have. What's the right stuff, okay? But again, the other thing that's important to know that there's plaques are common as you get older, okay? There's different things that occur in your brains. It's just the quantity of it, okay? But these accumulation of different things in your brain causes slower speed of information processing as you get older. So again, I'm going to say that slower speed of information processing. Again, just because it's important. Okay? So it's the same thing as TV nowadays. You have multiple programs, but there's 50 million things going on. Okay? I love the Blacklist. Anybody like the show Blacklist? Okay? I watch it at 9 o'clock at night after a long day, or even if I watch it earlier than that. I can't figure out what's going on. Okay? Because there's a lot going on. Okay? But I can't keep up necessarily. All right? And the reason why is because I'm distracted, it's the end of the day and everything else. If I was in a movie theater and there was nothing else going on, potentially, you know, it would be easy. But the point is the speed of information processing. If you're not catching it as it's coming out, it's not sinking in. And I think that that's why people get concerned thinking it's a memory issue, when potentially it's your brain is not working as quickly as the information is around you. So it's not necessarily a memory problem like Alzheimer's, okay? Because as we get older, our brain in terms of speed of information processing gets a little bit gradually slower. Now I'm going to talk about mild cognitive impairment, and there's many different types of mild cognitive impairment. It's been proposed to be that gray area where a large percentage of people with mild cognitive impairment will likely develop or possibly develop early onset or early, stages of Alzheimer's. And these are folks that on memory testing, or if I'm a neuropsychologist, they are scoring lower than the 16th percentile on memory stuff. Now again, what's really important is not using one specific test, not counting on one specific person, looking at neuroimaging, all those kind of things to help kind of solve the pieces and looking at the puzzle, okay? But long-term studies suggest that 10 to 20% of those 65 and older may have mild cognitive impairment. And if you're potentially one of those people, and you'll say, well, how do I know? Well, part of that is to talk with your doctor and get yourself checked out. But the other thing is to start looking at the friends around you, your friend group. And if you're the one that's having more problems with memory than they are, and you're the same age as them, that's a good potential way to kind of rate yourself. Okay? You don't want to rate yourself as somebody who's not your age, but somebody that's within your age group. So not to bore you with statistics, but again, here's the standard deviations, 2%, you know, as you can see, that the 16th percentile is the folks that are -1 and below, okay? But in this religious study, they looked at 211 people, and they followed them for 4.5 years. 30% were deceased at that time, and 34% converted to Alzheimer's disease. We look at the Mayo study here, 220 followed for 3 to 6 years, and I would say anything that says Mayo in front of it tends to be maybe more legitimate. But here's the Mayo study, 220 followed for 3 to 6 years, about 12% per year conversion rate to Alzheimer's disease. So evaluating mild cognitive impairment. What would I want you to tell your physician, your psychologist, your neuropsychologist, whoever that you're going to be seeing, nurse practitioner, PA? This is what, in a perfect world, I think would be helpful, okay? A thorough medical history. Thorough medical history, you get just any problems that you had in your life. When you were born on time? Did you have any problems growing up when you were learning? Were you somebody that was hard in terms of learning with reading? Were you somebody that was above your class? Or even if you didn't go to school because you didn't have the opportunity, are you somebody that really did catch on very well? Okay. Then assessment of independent function and daily living activities. So again, we have the basic activities, grooming, self-care, and then we have the instrumental ones, which are balancing your checkbook. Those sorts of things that if you used to be able to do that well, and now in the internet age, it's not as much of a relevancy. But if you used to do that well and it's really tough for you now, that's important to take note of. Input from family members, trusted friend. Again, we need that kind of secondary information. Whether they can't come with you, but they write a letter on your behalf, and contact information, and you can sign a waiver for them to contact. And then obviously an assessment of mood and anxiety symptoms, because depression is very prominent. Also anxiety. They did a study of folks that, I haven't written on here, but who found out that they had the APOE gene for Alzheimer's. And these folks did testing, and they did worse on testing because it was sort of a self-fulfilling prophecy for them. Okay? So it's important, again, that we look at multiple areas. So mild cognitive impairment, one thing that I currently use is the Montreal Cognitive Assessment Test just as a screener. But again, this is just a quick and dirty thing that we want to not take a serious diagnosis like mild cognitive impairment or Alzheimer's and say, oh, here's a 5-second screen, this is what you got. Okay? But again, there are things available that can help guide your decision on what's going on. So now we're going to talk about vascular dementia. It's about the second or third most common. In San Antonio, I would imagine, I don't have the rates, but I think it would potentially be more prevalent. And that's because of diabetes or other cardiovascular risk factors. It's also greater risk among men and African Americans. And essentially, there's another risk factor, hypertension, smoking, obesity. And this is something that oftentimes can be seen on MRI. But here's just another type of what your brain, if you look at the middle, the two things that are kind of coming up, your carotid arteries, it goes to the middle cerebral artery, which kind of branches out. And these are all areas of your brain where there's tiny little, you want to think about it like a tree, right? So you have your tree trunk, and then you have all the branches that are kind of permeating throughout. And so if you have a break in the branches at anywhere, that can be a problem. This is something else that we use, the modified Lipinski scale. And this is to let you know whether or not you are at greater risk for vascular dementia. Okay? Some of the things, the risk factors that I've talked about here, though, is recent stroke or stroke history. If this is an abrupt onset, if you have an abrupt memory problem, all of a sudden, just after this event happened, that tends to be, getting your brain or talking to a physician, talking to a doctor and saying, hey, what are the risk factors? Hey, smoking, obesity, high cholesterol, all sorts of things, hypertension. And what we talked about with neuropsych findings for Alzheimer's disease is, again, the short-term memory issue is going to be the problem, and potentially the word finding issues is going to be the most early onset type, what you're going to see. But for vascular dementia, there is going to be a difference, potentially. They're going to have slower attention. Okay, there might be some evidence of basically some planning issues, copying figures, those kind of things. Now again, this is just to show you, not by diagnosis, and I don't diagnose people based on a table, but again to show you what there is out there to help give you more information on what potentially is going on. Dementia with Lewy bodies. How many people are familiar with dementia with Lewy bodies? Okay. So one of the hallmark features of dementia with Lewy bodies is hallucinations, visual hallucinations early on. And the other thing is obviously the evidence of motor problems. So it's going to have, you're going to show, again, it's a degenerative disease. It's about 7 years, maybe give or take. And there's going to be striking fluctuations in cognition. Okay, the early stages. This is going to move a little bit faster than what we see with Alzheimer's. If you look at the pathophysiology of dementia with Lewy bodies, you're going to see the actual, potentially the Lewy body cells in the brain. The pathologist will. And, but it's, brain biopsy is generally not done with dementia with Lewy body. Now, oftentimes when I ask people about, did you have anybody with Alzheimer's in your life early on, or anybody in your family history, sometimes people will say, yes, my aunt did. But when I ask more about their aunt, potentially it might not be Alzheimer's. Okay? Again, we look for risk factors. We look for those types of things. Frontotemporal dementia. This is a devastating illness. I know of 2 cases, 2 people, when I was a fellow at the Army Medical Center, and I was in the Army for 10 years. So we had 2 cases. One was a chaplain. He was very, very well respected. He was in his 60s and grew up Orthodox Jew. And essentially, as he was getting in his 50s, he was a reservist. Went over to Iraq. They kicked him out. This was in 2008-ish. Okay? Nobody was kicking out religious folks. The U.S. Army and the U.S. Air Force, the Navy, they would have taken every chaplain they could get. Okay? So to kick somebody out like that at a theater, there was serious problems. He came back home, was caught stealing at Best Buy. He was then basically caught and arrested for stalking. He had gotten into yoga, very fascinated with yoga, then got fascinated with the yoga instructor. And his wife came in sobbing, just thinking, this isn't my husband. I don't want anything. I just don't know what to do. They were going to chaplain him out of the military. And he came into our office, and my supervisor, a brilliant man, says, has anybody taken a picture of his brain at all? Seen what was going on? Instead of just writing him off and saying he has a personality disorder with narcissistic features. And sure enough, they took they showed through a PET scan that had significant frontal loss in his brain. It was consistent with neurotemporal lumbar dementia. So this again, I put these pictures up here, but it's very serious, okay? But if you notice people as they get older, that all of a sudden are acting extremely irrational. I had another dentist when I was in the military, and he went to go get his Cadillac oil changed and came back with a new Cadillac. And his wife said, he bought a boat the month before. We don't have this kind of money. And we're moving into a retirement community. So again, we need to be looking for this as a community too, because these things are devastating. There's other diseases associated with cognitive decline. HIV. They're not sure if it's because of the antiviral agents that are used or the disease itself. And there might be somebody out there that can have a better explanation for me. But that's something that can potentially be a cause for dementia. Parkinson's, about 20 to 40%. And MS. Okay? Now MS, it depends on what type. You have the relapsing remitting, you have the chronic progressive. So you don't want to say all people with MS, okay? Because there are subtypes within that. So neuropsychological profiles. As a neuropsychologist, okay, what do? I look at all these areas of functioning that I talked about, visual spatial skills, look at language skills, look at memory. I look at all different things that, the neuropsychologists here in San Antonio and all throughout have looked at different patterns. And these patterns can sometimes be very helpful in addition to, obviously, neuroimaging. Neuroimaging is excellent, okay? It has its drawbacks. One being that it's very expensive, not necessarily going to tell you everything, and also many of which it's not paid by insurance. Okay, PET scans, I'm almost 99% positive that unless you have some kind of insurance that I don't know about, it's not going to be paid. So, can we have some hints then? Some of these hints. Behavioral problems. There's an increase in Alzheimer's, especially from when it goes to the hippocampus to the frontal areas. So there's going to be some impulse control. Maybe the person's going to be more outspoken than they used to be. But that's primarily going to be frontal temporal lobar degeneration. You're going to also look at executive functioning. Well, what do you mean by executive functioning? Well, that's the ability to know something's going on here. Like, how many, moms or dads that had multiple kids? Okay? You had book club, you had soccer practice, you had, oh my gosh, there's that one time, that 30 minutes that I like a program on the TV that only comes on that I have to make sure I remember to watch. And you have all sorts of things going on around you, and you have to multitask. Okay? That's what we mean by executive functioning, but it's a very kind of large word that people use that's sort of obtuse. But it's a sustained attention. It's the ability to control your impulses, make good sound decisions, not gamble all your money away. Okay, those are sort of the things that I mean by executive functioning. Also planning, organization. But you want to look at somebody's sleep. If they're acting out in their sleep, and that's something that's new that they've never done before, that's something you want to talk to your provider about. Okay? Psychomotor slowing. If we look for psychomotor slowing, people who are having vascular dementia, they're going to walk oftentimes very differently than folks with Alzheimer's, especially in the earlier stages. Okay? So you're going to have somebody more with a magnetic gait. When you talk about, they don't really pick up their feet as much. And it's different than a shuffling. But these are certain keys that can be helpful for folks if they're looking for it. In terms of the profiles, this is just sort of, again, a gross evaluation. But when you have people who are doing a cube drawing, okay, so copy or draw a cube for me, okay? People with Alzheimer's will have a harder time drawing the cube because it's harder for them to recollect it in memory. But if you give them a cube to trace, they can do it, especially if it's the earlier on stages, okay? So people with vascular dementia, though, tend to have a harder time with the cube, just drawing it, even when it's there, okay? So again, there's all sorts of nuances in terms of what can be helpful to figure out what's going on. Language fluency, Alzheimer's, they do fairly well on, if I say, give me as many words as you can think of that start with the letter G, okay? But if I say, tell me all of the things that you can think of that you can find in a grocery store, which involves semantic networking, okay, memory, they're going to give me a lot fewer items than somebody else who doesn't. The problems that some people with Alzheimer's will have, potentially, is that they'll make subordinate errors when they're speaking. So instead of acorn, they'll call something a nut, okay, so they're overgeneralized. But people with vascular dementia, they'll say acorn and then they'll call it a peanut, okay? So again, this is not a tried and true explanation, but this is something that can be helpful for folks. Do you have any questions for me?
I don't have a question, but I'll share a funny with you.
I'm all about that. That's great.
I do MOCAs on the unit, and I have a populace of 65 and older, and I'm always amazed at some of the answers I get on some of these. And I'll share about a year ago, I had this sweet little old gentleman coming in, and if any of you know what a MOCA is, it's pretty, well, she showed one earlier. It's the Montreal Cognitive Assessment Test. And you've got 3 animals that you have to identify. This little gentleman, bless his heart, when I showed him the lion, I said, can you tell me what this animal is? And he goes, that's a very big dog. And so I said, okay. And I whipped out the animal next to it. And it was rhinoceros. And he looks at it and he goes, it's one of those animals that goes under the water. I said, okay, very good. Now we're down to our last animal. Can you tell me what this animal is? And he's looking at it real hard and he goes, that was back during Jesus' time and it used to carry stuff. So,
Very descriptive. Yeah, language is great in terms of ability to kind kind of use words to describe, but again, a memory issue. Yeah.
We have neuropsychologist profiles. Can you have Lewy and Alzheimer's?
I think so. I mean, there's yeah, and I'm glad you brought that up. So, most people, there's never anything cut and dry. You can have a mixed dementia. So you can have vascular dementia and Alzheimer's. You can have both, absolutely. Yes, Helen, you need to...
No, you're carry on.
Does your testing show that?
Not necessarily, no. That would be more for neuroimaging probably, or you know what, even in still with Alzheimer's, the only tried and true way of knowing if somebody has Alzheimer's is by autopsy. So that would be really the main thing. Okay, yes? I would imagine not. TRICARE for life, pay for a PET scan. I had TRICARE for a long time. I don't think... Oh, okay. Did you hear this? Medicare will pay for one. Okay. Okay. Okay, well, that's great. Right. Okay. Anybody else? Yes, ma'am.
I'm hearing a lot, especially in the sport industry, about head injuries,
Yes.
related to Alzheimer's. How passionate about.
Well, I would, you know what, I have to probably think before. This is what I want to say about that, because I want to make sure that I don't say anything that the ethics involved with being a part of a research and then sitting on a panel for the NFL is not appropriate in my book, okay? So there's a lot of folks, and I'm not saying all, but there are a lot of folks that have made gross assumptions when it comes to head injuries and likelihood of Alzheimer's. Gross assumptions. And so the data is really just not there. Now, when we talk about the media and looking at research, we assume that the media is going to cover all the research behind the topic. They're not. Okay? So, and also, the studies that get published in journals are the ones oftentimes that are, you know, the ones that people want to read. And oftentimes people don't want to read that studies haven't been found. Now, I know Anne McKee, okay? I don't know her personally, but I've met her several times, and she's out of Boston, VA. She's the one that talked about the tau buildup. We all have tau buildup, okay? But what I want to say about that is always ask, how was the person beforehand? Okay? How was Junior Seau? I never met him, okay? He was I guess he had played for UCLA and then went to, I think, the Saints, or somebody's going to correct me, but how was he before this problem? Well, he had multiple arrests. He had multiple problems before, potentially. So we want to make sure that we don't go for what's shiny and interesting and call that science. I also want those folks over there in that specific area to collaborate with other places to see if there's data being found over there. Share your data. We require that for the FDA for medication, but we're not requiring that for studies related to concussions. So again, the standard, the ASMS test, or the standard litmus test, needs to be there, and it's not. So there is some faulty conclusions being made. Now I have a little girl, so I don't know if she's going to want to play football. My brothers were never allowed playing football growing up, okay? So I don't necessarily want to take the chance, but that's because I'm a pretty protective person with my daughter anyway. Okay, so that's my style. But in terms of looking at, there's been egregious faulty logic when it comes to that, in my opinion. So there needs to be more science behind it before we completely change the view of the nation and how we're doing it.
We have a question on the side of the room.
I
Yes. Sorry, I'm on my soapbox.
I'd like to share an experience with my girlfriend. We would visit often, and once I noticed that she had shuffled gait, and she also had slurred speech. And I didn't want to really mention it until she brought it up. And it turns out that she fell at work, and that she was being examined to see what was wrong. Because of workman's compensation, she fell at work.
Yeah.
After testing, she was diagnosed with Alzheimer's. And when she finally told me her diagnosis, I said, Esther, Alzheimer's? I have more Alzheimer's than you do. I said, I do forget things. I forget where I put things, and then I can't find them, and I'm looking all over for them. And she had excellent memory. And I said, you better get a second opinion.
Sure.
She did. After a year. So all of 1 year, she was diagnosed with Alzheimer's. She was placed on disability from work and retired. Turns out, she was finally diagnosed correctly with Huntington's disease.
Wow.
From Alzheimer's to Huntington's disease.
It's even more devastating.
Yes, more so. And that's why she had her slurred speech and her shuffled gait, but she had intact memory. She still does. Right now, she is using a walker and a wheelchair and living in a home. But I was so very pleased that she finally got the help she really needed. And I still say, I have more Alzheimer's than she does.
Agreed. Thank you.
Right over here.
So again, really important that you have family members, friends that can help with the assessment. We're not always great at our own self-assessment either. Yes?
My question is similar to what this lady spoke about earlier, just now. As a do neurologists and the medical profession, do they have a standardized test that they use? Because when my mother was diagnosed, there were different tests, the cognitive or the memory, the standardized tests that they give. And do all neurologists use the same test? Is the one that you showed up here the best?
Well, yeah, that's a great question. No, everybody has their own different testing, and Dr. Boyle would be a good person to answer this too, because I know he has his own battery. I think generally the minimum mental status has always been the sort of gold standard. But what I've decided to use more is the Montreal cognitive assessment, because to me the validity is better, and there's 4 different versions. With a mini, you have somebody that's been seeing, Penny, Amyloid. I mean, you can. Hey, I know my husband has memory problems, but we've been going to you for 5 years now, and this is the 20th time that you've given us the mini mental. He knows it. So what I like about the Montreal cognitive assessment is there's 4 different versions. There's various of English, but there's Spanish, there's Turkish, there's
Also one for the blind.
There is one. I don't know.
Yeah, there is.
There is one? Okay, great.
For the blind.
Okay. So there is one for the blind. So I like something that can be alternate versions available. But I know in our research trials that I'm currently a part of, we use the mini mental because it's part of the actual research protocol. So, but to answer your question, no, not everybody has different tests. I mean, not everybody uses the same tests. As a neuropsychologist, and I'm biased toward testing using neuropsychological testing, but there's different screeners that you can use. And when I see a patient, I generally see them for about 5 hours, okay? Maybe a little bit more. I do a good, clean interview. I ask them questions. I talk with their family members. That lasts about an hour. I do some psychological testing where I'll ask them about their anxiety, attention span, all those sorts, anxiety and depression. And then I do several kind of memory tests, and I look for if it's an encoding issue issue? Is it a retrieval issue? Is it a storage issue? Where is the breakdown? And there's many different tests that will measure that, but I say you just want to make sure that it's a collaboration that fits into the puzzle. That piece fits in the puzzle of what you're overall seeing. So not using one test to say, oh my gosh, somebody's demented, okay? But using it maybe as a way, and there are a lot out there that, as long as they're empirically validated, and not all neurologists use them, not all psychologists use them, not all psychiatrists use them. Some people say, oh, I can tell, I've seen this individual for 20 years now. I have a story about that. One of my supervisors, not the one that was great, but another one, she wanted me to do some testing on a couple that she'd been seeing, and she couldn't do it because she's been seeing a couple. She said, I don't think there's anything going wrong, but he wants a testing, and you haven't really had any stroke cases lately, and he had a stroke like 20 years ago, so why don't you see this person? Well, what I found out was that the person was grossly impaired and had been seeing her as a couple for like 10 years. He just didn't talk much in the sessions, which is kind of crazy, right? How can somebody miss that? But if you're seeing somebody, it's that accommodation. You see them every day. You know them. You want them to be good. You want things to be right. And you can miss it. So you need an objective person. And if you feel like that objective call is wrong, I would fight to get a second one, because it can save your life. So.
If I take this information that I've learned, I take it home and I share with them, they may not accept it. They may not do anything with it. And so what you just said, it just sparked that question.
Yeah, that how do you get people, the knowledge that you're learning, and you have people at home that might need to know this. Yeah, that's the toughest part, is getting people, because there's a lot of defensive-ness, right? People are scared. They're scared nowadays, and so how do you get somebody? I think it depends on your relationship with that person. And sometimes people will say, anytime we have big problems going on in our family, we meet as a group and we talk about it. That might work for some people. Other people, it's going to a priest or going to a rabbi and you speaking with them and saying, look, we're going to need some spiritual guidance here, and helping to figure out, helping this person, adjust and receive this information. But yeah, there's a lot of stages of acceptance, and denial is the first one.
We've attempted that for the last 5 years to gather all 7 siblings, with or without my mom, but all 7 siblings.
Yeah.
And it just hasn't happened.
The other thing too is, this is out of my scope, but the other thing too is talking with an attorney. That might be good. Helen, you have a lot of experience in this, so if you want to chime in, or anybody wants to chime in about these questions, because I want this to be kind of a community collaboration.
Well, as a former caregiver for my father and child number 7 out of 8, I too had some family dynamics that came into play, but one of us had to stand up and really take the helm. And so it was my job. My father chose to come to San Antonio, but it was my job to delegate to my siblings what my needs were. Again, my father was cantankerous, he's an old Irish Catholic. How do you get along with one of those? But the fact of the matter is that my father chose my husband and my home, and so we took him in. With that being said, I had to be very clear with my expectations. So one sibling, we put all of his bills on his Discover card. She took care of the finances. Another sibling called down on Tuesdays and Thursdays. Another sibling would come down about every 90 days. He could afford to do so, So I had to be very clear what my needs were as the caregiver. So if you do have that, I know I have some client family members here that are going through the same thing, where you have to be specific with your needs as the caregiver for this particular individual. If you haven't had a come to Jesus with your siblings, then someone's going to have to take the helm and be the advocate for your loved one. And of course, the geriatric care manager comes into play too. If there's just so many dynamics, and you can hire that individual, and we work with many here at the Alzheimer's Association. So,
Yeah, there's a lot of great people here in this room, so.
Real quick, is there any science behind this idea that's being thrown out there that you can exercise your brain with crosswords and that you can slow down this process of aging?
So I'm gonna, again, give you my opinion on this, okay? And I'm not gonna name which software programs are out there, but there really hasn't been impressive empirical validity that's gonna be helpful, okay? There's a lot of money behind those things. So whenever there's money, in my head, I oftentimes get a little bit skeptic, but unless somebody else wants to speak to that, I would say that the science behind that is not there. Now, it might get you better at being at that game, okay? No, seriously, that's the thing, is that, you know, it might get you better at those types of games, but does it have what we call ecological validity, okay? And that's sometimes the struggle with neuropsychological testing too, is the ecological validity. How does this test equate to the outside world? And that's why, again, informants are extremely important. But in terms of what I would say about that is the type of person that would try those things. That person that's always looking to say, how can I do things to make myself better? How can I, whatever. Somebody in that personality style is going to be somebody that makes choices throughout their life like that. I'm going to do something new. I'm going to try this. And as we know, that with the aging process itself, as you get older, if you retire at 50, like my father did, and you don't do anything else, and I love him to death, but he wouldn't do very well on most standardized testing or OPAs or anything else because his brain has sort of just kind of sapped it. So had he been the one in his 50s that says, let me try this, or let me try this, or let me go to this place, those types of things, I think that's great for your brain. Does that make sense? Okay.
My question is, you mentioned about getting siblings involved, but my siblings and I have been going over this a couple of years, and we're finally having a family meeting Monday. My mom's been gone for 16 years, and what I'm finding real challenging is reaching his doctor, because my daddy was a very charming man. He line dances 3 times a week, ballroom dances, has an 82-year lady friend, and hey, I'm fine, but when I say, Dad, you almost drove through a fence.
Yeah.
Dad, you're at the altar giving your daughter away, when they said, who gives her away, and you're standing there, and I'm noticing things. And I told him, I respect the fact you have to honor confidentiality and HIPAA. So finally what I did is went to his siblings, and my sibling, because he's in Ohio, I'm here, and I contacted my dad's aunt. She contacted the brother in Ohio. The brother in Ohio has the same doctor, because the doctor didn't believe my sister. I'm like, I'm a 63-year-old woman. I don't have any problem assessing something to know it's not his norm.
Sure.
So it's finally taking medication, but this has been over a period of years. What recommendations do you have to reach the doctor who looks at him and says, oh, you know, Mr. Wilson's fine?
That's a great question. I don't want to drag Dr. Boyle into this, but he might have some ideas. But I think for myself, sometimes an email. Okay? I'm not allowed to talk to you, but you can certainly provide me information. I just can't, I can't ask for it. Okay? That's how I abide by HIPAA. Other people might be very different. Okay? But the whole spirit of HIPAA wasn't to prevent information from going to the people that it needed to. So I would think writing them, if they have a website where there's comments, and don't necessarily say, hey, that's going to get there. But even if you need to send through the mail, what's that when you sign that has to be received? Certified mail, there you go. Yeah, I think that can be sometimes helpful, but that's a very challenging situation that you're describing that I think is more common than not.
Sure. And an elder law attorney is going to be speaking this afternoon, and she's going to be addressing this very thing. And it's talking about getting on your dad's medical power of attorney to be able to make healthcare choices and comments and decisions.
Now, one quick question too. You were mentioning that, well, we were talking about brain games and things like that. Last year, I think it was, the newspaper came out with an article about the study of Olga. I don't know if you read it or not. The lady is in her 90s,
Okay.
and they found, or at least their research found, that if you were physically active, that it helped increase the brain power and things like that. When she started becoming active, she's now one of the oldest supposedly senior citizens, and goes all over the world doing her long jumps and track and all this. They said that she started this in 87, but they found in their research that being active and not being I hate to say it, a couch potato, really helped them. Do you believe that physically being active will help that?
Yes, absolutely. I don't have the exact science behind that, and maybe somebody else does in the room, but I think physical activity is huge, because what we also say, and I think somebody over on this end asked about, can you have both? Vascular problems and Alzheimer's, absolutely. So the physical activity really will help to prevent the vascular changes that tend to occur as you get older anyway. So healthy diet, activity, going out, doing things, just stimulating your brain, I think is crucial. Now, I also want to make sure that everybody understands that one person is not necessarily generalizable. Okay? NFL players are not generalizable to the public. Okay? Does that make sense? Okay. Yes, sir.
One thing that I've been hearing in the news and on PBS and places like that in general is about some of the newer studies about the plasticity of the brain and how my understanding of it as a liberal arts person is that when you lose function in one part of the brain, sometimes other parts of the brain can compensate for it. And in something like Alzheimer's, which we're going to be facing, or are facing, is there any kind of activity or any kind of therapy, that is non-drug related that might help to stimulate other parts of the brain that might help compensate for losses in?
Yeah, that's a great question. It's a complex question. When I think of neuroplasticity in my own training, I think of differences that occur early on from when you start as a baby throughout. So educational factors, medical diseases that were incurred as a child, or medical diseases during early adult. If you're somebody that was fairly healthy early on and weren't exposed to neurotoxins, you weren't necessarily a termite inspector throughout your whole life, which sometimes I worry about those guys, because of the exposure to toxins and those sorts of things. But I think that neuroplasticity is where you have these factors that, even though there's changes going on in your brain, because you're highly educated or because you are essentially somebody that can compensate, when you have this disease process early on, it might not show. So it's the same thing as a genotype versus a phenotype, okay, for those people that are tracking. So, like, basically, it can show up in the cellular level, but is it going to manifest in a day-to-day operation? So somebody that's a surgeon, that's been doing surgeries until they're in their 80s, and they're excellent at what they do, and then all of a sudden they retire, and what happens is that sometimes in that retirement, the wife will say, he doesn't have good ability to learn new things. Well, he was able to compensate because he's so bright. Okay? He was able to use his problem-solving skills, all those sorts of things, like the amnestic disorder type that Dr. Boyle talked about earlier. The person could then organize themselves to the nth degree. So what are some things that you can do to teach how to prevent that from occurring functionally? I would say is organization, healthy diet, good sleep, basically getting vaccinated, whatever you need to do to prevent yourself from getting other diseases. And, then when you are in the latter stages of your life, maybe thinking about, okay, let me make sure I get things organized. Maybe make sure that I develop, memory strategies, association tasks. There's a lot of things that you can teach yourself in terms of memory in the encoding stages. Okay, the encoding stages is the piece that, while you're paying attention, it's that start from where it's attention to all the way sinking in your brain in memory. Okay, so that encoding process, the better you encode the information, the more likely it is to stick. So I think that's getting to where your part is those sort of books on learning memory strategies. All those sorts of things are great for anybody. If you're passing the test and you're in your college years and you're trying to, whatever you need to do. But I think that memory strategies can be helpful for everybody, including people with early memory changes.
Dr. Kate, thank you so
Thank
much
you
for
very much.
sticking around.
Remember, research, Thank you.
And people have been commenting, we haven't been saving time for questions, just know we're aware that our speakers have had some schedule issues, so thank you for being patient with us. And so it's lunchtime, and I'm going to make you work for lunch because we have drinks in a separate area from where your lunchbox is going to be. So where I'm standing right here, so the room right here, these sets of tables to the right, my right, I'm going to ask that you go grab your bottles or your beverages. We have coconut water, Gatorade, bottled water. So if from this table over, head on out to the Memory Cafe area and grab your bottled waters. This section of the room, we're going to send you through the lunch line. Now we do have vegetarian meals. We also have gluten-free meals. So just let us know what you're looking for. And you're going to see where the light came on. They're opening up the doors. You're going to be like a rat going through a maze. And I'm going to ask that you go through the doors and pick up your lunch and come out. Okay? Thank you.
Has a sheet of paper that you can
Into this house we born, into this world we flow, like a dog without a bone and nectar out alone, riders on the storm. There's a killer on the road, his brain is scrumming like a toad. Take care, Lord.